Okay. So this is a part 2 of respiratory MCQs 4 in that part 2. Previously we have discussed previous around 12 questions. Some more 10 more are left on pneumonias and we will be discussing today. So the first MCQ of today is, so all of the following are seen in viral pneumonias except. So viral pneumonias, what type of pneumonias they produce? Pathologically,
Interstitial.
yeah, there are three
Yes,
types: broncho and interstitial. Okay.
yes,
Of them, viral pneumonias produce interstitial pneumonias. So presence of it is except. The question is except. Presence of interstitial inflammation. Do you think it is yes? Yes,
yes,
correct. It is
yes, sir.
correct answer. So it's not except. So presence of alveolar exudate. So interstitial pneumonia is a edema of the bronchial walls predominantly. Huh?
Yes,
Here the inflammation is there. Huh? There could be some surfactant, all here layers can be there inside, but predominantly the disease here. Interstitial pneumonia, interstitial here. So what is bronchiolitis?
sir. It's caused by respiratory syncytial virus, mainly in
Yeah,
children.
infants, children less than 6 months. Okay. There these viral pneumonias can cause that. So multinucleated giant cells in bronchial wall.
No, sir.
Hmm? So it see the what is the accept answer here? You think this is correct? Alveolar exudate. Where is the alveolar exudate seen?
Low.
Lobar pneumonia. Alveolar exudate is classically seen in lobar pneumonias. So in this is the correct accept answer. Multinucleated giant cells are seen in viral pneumonias. What are the cytoplasmic inclusions? Where you get intranuclear inclusions, intracytoplasmic inclusions. There are intranuclear inclusions as well intracytoplasmic inclusions. Where you get them? This is in RNA virus. Intranuclear is in DNA virus. Okay. Huh?
Yes.
I'll
Okay.
come to that. So this is the accept answer. Hmm? So the predominantly these are the viruses which cause pneumonias. That is influenza. Trump keeps on telling this influenza virus. In his favorite,
Yes.
he keeps on telling this Trump. Remember that. He is actually talking about this pneumonia, which is there, which is more seen in temperate climates. So he keeps on telling this. So he thought this is COVID is like influenza. Let us not worry much about. Now he is paying the price for that now. Influenza virus. Then comes his respiratory syncytial virus. Just now you told me that, and para-influenza. These are the predominant. Three are coronavirus. All those things are there. I'll not go to that now. Influenza virus. The predominant will be the patient will present with cough, headache, fever. The cough will be dry cough. Huh? Okay.
Yes, sir.
The cough is dry cough in viral pneumonia. Huh? For that matter, in interstitial pneumonia, it produces dry cough. Because alveoli don't contain any much exudate there. That's the reason. So dry cough, headache, fever, myalgia. This is this person like influenza virus. Then the other virus is respiratory syncytial virus. So LRTI and pneumonia in children, that is above 6 months. Below 6 months, as you said, bronchiolitis. This respiratory syncytial virus produces. So the again cough is fever, non-productive cough, otalgia, ear pain, otalgia, anorexia, dyspnea will be there. Wheeze and rails are the features of RSV virus producing viral pneumonia above 6 months. Okay. And below 6 months it is what? Bronchiolitis.
Okay.
Para-influenza virus similar to this. Don't know much difference. Above 6 months it is pneumonia LRTI. Below 6 months it is what? Bronchiolitis. That's about viral pneumonia's clinical things. Now, as you said, it is an interstitial pneumonia. See, as I said, told you, DNA virus produce intranuclear Remember this. DNA is intranuclear. RNA is intracytoplasmic inclusions. Huh?
Yes, sir.
Inside the cytoplasm, inside the nucleus. That's the difference between them. Viral cultures, you have to do PCR. You must bring. You know about this PCR. If it's RNA virus, RP, reverse PCR. And serology. Serology. Then chest X-ray and lung biopsy. You can use for that. Then the treatment. Treatment is influenza virus is amantadine hydrochloride and ramentate hydrochloride. You can use for influenza virus. And RSA virus, the only drug available is ribavirin.
Bavarian.
Ribavirin. And if you are dealing with a para-influenza virus, mainly supportive and oral or aerosolized, ribavirin can be used. This is the treatment for these people. Okay. Now we'll come to this pneumocystic carni pneumonia. Pneumocystic carni pneumonia. So pneumocystic carni is where you get pneumocystic carni pneumonia.
Sir, in HIV patient, sir.
That is yes,
Immunocompromised.
when they are in the later stage. Okay, pneumocystic carni pneumonia, all are except. Then what is the interstitial pneumonitis? Do you think it is correct?
No, sir.
It doesn't cause an interstitial pneumonitis.
It's
Yes,
a
sir.
Pneumocystic carni causes interstitial
yes, sir.
pneumonia.
Yes, sir. It's causes, sir.
It is neither lobar broncho interstitial. It is interstitial. Lobar the pneumocystic carni produces interstitial pneumonitis. That is okay. Does it cause a eosinophilic exudate?
Yes.
Does it cause vacuolated intra-alveolar exudate?
No.
And the third one is damage to type 2 pneumocytes. Which one of them is true? I mean, false. So there is a pneumonia means actually the type 1, type 1 pneumocytes get damaged. Okay. In pneumonia, this one there is a type 1 pneumocytes get damaged, and these are replaced by type
Type 2.
2 pneumocytes. So here the question is damage to them. In fact, there will be hypertrophy rather. There is a hypertrophy of type 2. It is a hypertrophy of type 2 pneumocytes will be seen in pneumocystic pneumonia. So what you are seeing it is, so this is actually except answer. This is your answer. So interstitial pneumonia is true. See, these two do happen. We use H&E stain. H&E stains if you do for the lung biopsy which you take, or exudate that you collect from the alveoli by ball technique, you can see this eosinophilic, especially lung biopsy you can get these two. Lung biopsy if you take these with H&E stains you get eosinophilic exudate. You can see that. So this is the answer. Got it?
Okay,
Okay,
sir.
we'll discuss something about pneumocystis pneumonia. Pneumocystis pneumonia seen in HIV, immunosuppression, transplant, and glucocorticoids patient. The patients who are with this, hold on a second.
One second.
Hold on a second. Sorry, I had to attend a call. Okay, I'm back now. Fine. Okay, then here, so immunocompromised, HIV, immunosuppression, these are the cases where you get pneumocystic pneumonia. So it is actually, there was a issue whether it is a protozoa or a fungus. These issues are there. This was the issue. Now it is concluded as what? Fungus.
Fungus.
Okay. Now pneumocystitis is accepted as fungus, not protozoa. If you see some old editions now, you may get confused whether are we dealing with a protozoa or they may give like that. This new text, they definitely make it a fungus now. It is classified as a fungus. This can come as your MCQ because now conclusion has come out. And actually, when a pneumocystic carni, this is now actually in humans, this is the name. Pneumocytis
Jirovecii.
jirovecii is the modern name for the infection that happens in humans. If it happens in the rats, then it is called as carni. This okay, and actually we should be calling this. This we call it as PCP, pneumocystitis carni pneumonia. We call, but we should actually call it as PJP. Okay, of course, this is
Yes, sir.
okay people to accept, but this should be the correct term. It is acceptable to call it like this also, but this sounds more relevant. Okay, PJP. Okay, that's it. So, pneumocystis jirovecii pneumonia in humans it is called. So, these patients, see, this is an organism which is present everywhere. So, all the infants will get infected. Infection happens by the infancy only. But they do not manifest with the disease. So manifestation of disease only happens if there is this immunosuppression, all this. So pneumocystic jirovecii or PJP, I'll put it as simple PJP, which only happens in immunosuppressed. Okay. Otherwise, disease manifestation does not occur. There was, in fact, if you read previous editions of Harrison, they will give you like this: there could be reactivation or new infection, all that. Now it is settled, it is more likely to be a new infection. This is important because you need to know whether it is a reactivation bar new infection. This is because isolation purpose. Okay, if the patient has a known case of pneumocystic pneumonia, he should be separated from other immunosuppressed patients. That is the reason there is human to human transmission. Human to human transmission happens here. So the isolation is required for immunosuppressed patients. If you got a patient of pneumocystic jirovecii, then you should not keep that patient along with the immunosuppressed patients. That's what we are telling. Okay.
Yes, sir.
That's what is the this one. Okay. That is the way it is important. So immunocompetent people get infected, but they don't suffer from disease. Okay. So separation from the immunocompetent may not be necessary, but separation from an immunosuppressed patient, other immunosuppressed, it is a necessity. Okay. That's
Yes,
the
sir.
reason new infection is important, is settling. So if you are diagnosing a pneumocystic carni, the diagnosis is achieved with the demonstration of the organism. So sputum is the one which you should use. But however, routine sputum, what we send, routine sputum is not enough. You will not get a routine good sputum. These patients have got a very dry cough. So you will have to induce them. Induce sputum with a hypertonic saline. So this is important. So if the question is telling routine sputum, will give. You should not accept it. The choice you should pick it up is hypertonic saline induced sputum. These phrases should be there. That kind of a sputum is used for staining to demonstrate this organism. Okay, got my point?
Yes, sir.
And
Yes, sir.
this is around 60 to 70% sensitive only. What is sensitivity? Madam has told you people. What is sensitivity? What is specificity?
Specificity.
Anybody? Madam has taught you, so I expect you to answer.
Yes,
Okay,
sir.
then I will briefly tell Madam. May just have told me. I will tell. I have not told. If you know, tell me. What is sensitivity?
Sensitivity is true positives.
Okay, true positives. You will try to pick up true positives and
Sir, it belongs to a particular means sir particular organism, uniquely for particular organism.
no. The
Specific.
question is so if the so in high sensitivity, a test which is now I'll put it more like this. Test which is high sensitivity. What does it mean? It should pick up all, most at least. It should pick up all or most high
Means yes, sir.
sensitivity. Means
True positive, sir.
that means true positives you should not miss. Hmm? True positives it should not miss. That's what it is telling us. High sensitivity means it true positives should not be missed. Hmm? Of course, we agree if they pick up some false positives. High sensitivity means most true positives. It should pick as a disadvantage false positives may also come in this. Got it?
Yes, sir.
Got my point? So high sensitivity test is the one which will pick up almost all true positives and some even as a dirty thing false positives will also enter as positives there. Got it?
Yes,
So
sir.
it is a good screening test. Okay, that's what they are telling us. Okay, now we'll go for specificity. A test which are what high specific means what? What?
True negative.
True negative, sir.
True, true negatives. Okay. What is okay? That is also. I'll put it in more clinical terms now. High specificity demands the test whatever come positive none of them should be false positive. The people whom we call them as positive, they should not be false positive. Basically, did I confuse you? The people who are declared as positive, among them, the false positives should be less or absent. A test which picks up. So in this event, we may lose some true positives. Did I confuse you?
No, sir.
High specific city test means it should not include. It should not include false positive cases. The purpose of high specific test is it should not include false positives. So if you try to make a test which is more not including false positives, you may lose some true positives in this game. If the criteria become very stringent, if I say, for example, if I say after 8 o'clock, I'll not admit students, it is more stricter, stringent. So the students will be lost. Some interested students will be lost. So whenever you become more specific, the true people will be lost some amount. But however, dirty things will not enter at the same time. When the test become more sensitive, almost all true positives will come inside. At the same time, dirty things will also come inside. Sensitive means you include. Specific means you eliminate.
Yes, sir.
More sensitive means
Yes,
you
sir.
try to include everybody, true and false. Come, like that. More specific means I will take only the good people. In such an event, some good people may also be lost, and false positives definitely will become very less. That's what these tests are meant for. Got it? That's how, as a clinician, we look at. Of course, madam will give you the more detailed approach to this. Okay?
Okay.
Okay. Now, induced sputum should be followed by BAL. What is bronchoalveolar? In case this sputum, it is what? It has got a less sensitivity. Sputum, induced sputum. Then you will got to go for BAL. Broncho, or that means you put a bronchoscopy right up to the bronchus and extract that from there only and see. So there will not contamination with saliva, this, that will not be there. So from the alveolar exudate, you can pick up the what? Bronchoalveolar lavage, you can see the organisms.
Yes.
So this will be more sensitive. Okay. Okay.
Okay.
That's what. So after this ball, I'll come to causes of it causes interstitial pneumonia. Okay. And one more thing, this pneumocystitis. What is this term? Cystitis is basically it forms cysts in the lung. The name, this here you can see na cystitis here. This is this referring here. Cyst in the lung it forms. Cavity, cyst in the lung. That's why we call it as pneumocystitis jirovecii. Got it? This cystitis is referred to this cyst in the lung. Okay. So
Yes,
these
sir.
two produce cysts in the lung. And so if there are cysts in the lung, then the patients are prone for pneumothorax. They can burst into the pleural cavity and patients can develop pneumothorax. A patient with HIV and AIDS comes with sudden onset of signs of pneumothorax. You should suspect PJP or PCP. Got my point?
Yes, sir. Sir, it's spontaneous pneumothorax or
Yeah, spontaneous. Very good. This spontaneous pneumothorax, you in young male, it is all your bulle. But
like,
here,
sir, emphytemus bulla?
what?
Like emphytemus bulla, sir? Like,
Yeah. But if a patient is a HIV and AIDS, if he comes to you with the signs of pneumothorax, I'm getting this binding here. See, AIDS patient coming with pneumothorax, rule out PCP in him.
yes, sir.
PJP, whatever this is, PJP. What is this? PJP you can call it. Old term is PCP. Now I want to call it as PJP. Got it? Because there is a cyst here, and this cyst will burst into the pleural space, and what it will cause? Pneumothorax. I'll show those cysts how they look. So there are two things in the pneumocystitis causes intra-alveolar changes and interstitial changes. So I was telling about eosinophilic. See, the choice contained this eosinophilia, foamy vacuolated intraalveolar exudate is seen with He staining. And this contains exudates contains organisms in all phases, trophozoite, cyst and all. They are seen here. And stains are special stains to be used to diagnose them: silver, right, Giemsa stain and Papanicua stain. These are to be used to diagnose pneumocystitis. And they also contain this surfactant, alveolar microphage and all that. Okay, this surfactant is more because there is hypertrophy of type 2 cells. Type 2 cells secrete what? Surfactant. You're hearing me?
Yes, sir.
Yes,
Type
yes, sir.
2 pneumocytes secrete surfactant. So there is a hypertrophy of type 2 cells in interstitial pneumonia. So you expect surfactant also to increase. What is the purpose of work of surfactant?
Sir, it's prevent friction, sir.
Prevents it from collapsing.
It collapse of the alveoli. It gives the
Surface tension is mentioned.
surface tension so that alveoli are kept open. Tension. It reduces the tension in the wall so that it keeps open. It doesn't collapse. That is the purpose of surfactant. So interstitial changes means mild. It will be so mononuclear cell inflate. This is what seeing that damage to type 1 pneumocytes and hypertrophy of type 2 pneumocytes. So this is the pathological part of it. So diagnosis apart from that ball, stain, all that. One thing I want to tell you, if there is CT scan is normal, you can comfortable without PCP. You take a CT scan and the CT scan is normal, then for it may not be PCP. You start searching for something else in HIV patient also. Okay. Then beta glucan is also elevated. This can be used as a replacement if you don't have ball. You ask for induced sputum, it becomes negative. And if your hospital doesn't have bronchoscopy, and if they have then you can ask for this test, which is a test which doesn't require. I hope nobody has come up. We'll go to radiological part. See, you these images are good. There are many good images. Have a look on them. Have some grip on these images and image-based questions. Now there are a lot coming up these days, and the questions of the pattern is slowly changing towards becoming more clinical approach. So that's why I'm going more deeper into theory part, so that the question the purpose of solving MCQs is to give you direction to study which are the topics which are important, which are the topics you have to read more. So if I start discussing more on PCP, then you should go and read out PCP even as a theory and try to look up the multiple ways for the same where all things can come. Like that. That's the reason we try to solve MCQs. So this is an PCP radiology patient. These are the cysts. You can see here so many cysts are there. And if they rupture into the cavity, pneumothorax will happen. Okay. These are reticular shadows are there. See so many. Reticular pattern. Interstitial pneumonia. And this reticular pattern starts on the hilum and spreads outward here in this case. Okay, it goes
Yes,
like
sir.
it goes like this. Initially it becomes in the hilum. The spread is from hilum to outwards. Yeah, like this. Okay. Treatment. Okay, cotrimoxazole, trimethoprim, sulfamethoxazole, otherwise also called as cotrimoxazole,
Relaxation.
Bactrim. Sometimes they may give this and a short note. You should know the trade name also. Cotrimoxazole and Bactrim DS. These drugs are this is a drug of choice for both
Yes, sir.
treatment as well as prophylaxis. Okay, I'll come to that. So if the infection is yes, some background noise, you can just switch off something. Okay. Cotrimoxazole is a drug of choice. Mild infection 14 days, if not 21 days. Now this is a table from Harrison, newer edition. So treatment for pneumocystitis is the first drug of choice is this one same cotrimoxazole. Dose is a bit on the heavier side. That is see here 2 double strength triamulates will be QID, TID or QID 4 times, 3 to 4 times. You can imagine the patients are Bactrim DS. He has to take 2 in the morning, 2 in the afternoon, 2 in the evening, 2 in the night. So 3 to 4 times he has to take. Such heavy dose it is. The patients made all of these side effects. Hepatitis, hyperkalemia, cytopenia, rash, and all that. They are usually seen. We do see patients. If you put them on this high dose of cotrimoxazole, we will may see these complications, side effects. Okay. This is a second drug. If the patient all of this, you can try this. Bit expensive. This bit expensive anyway. It can be tried. And for absorption, you have to give high fatty diet. Otherwise, go for intravenous. Otherwise, you can use clindamycin plus chloroquine and pentamidine. Pentamidine is given as a nebulization, aerosol. Side effects is bronchospasm, pancreatitis, astomia, cardiac arrhythmias, and all these side effects are there if you are using pentamidine. And sometimes if the patient has got a severe hypoxia, then you may be forced to give what? Prednisolone
Steroid.
or methylprednisolone to overcome hypoxia. Okay. So the PCP prophylaxis. So PCP prophylaxis is what is this? If the CD4 count is less than 200 ml, If the
Yes.
CD4 count less than 200 ml, the chances of getting PCP pneumonia increases. Huh? Okay. So you advise is to give them PCP prophylaxis. Okay. That is what. I'll come to what is the prophylaxis. And CD4 count is less than 40%. Huh? Okay. This is one more indication. And oropharyngeal candidiasis is a oropharyngeal. This is a diagram of oropharyngeal candidiasis. So if there is in a AIDS patient, huh? AIDS patient, if you see oropharyngeal candidiasis or this forms primary prevention, because this patient has not yet developed PJP or PCP. Hmm? But if there is what is this? This is a secondary, huh? Prevention. Okay. You're getting me? Because this patient has got a
Yes, sir.
history of PCP. Huh? So these are both these patients should receive PCP prophylaxis. Huh? Only thing name is different here. For this it is primary, for this it is secondary. Prophylaxis. Okay. Hmm? Getting me?
Yes, sir.
Yes, sir.
Yes.
Then prophylaxis. What are the drugs? Prophylaxis. So as I told, this is a drug, cotrimoxazole, 1 tablet per day. This is the most commonly used. So other thing is, if the patient has got a side effect, then dapsone, 100 mg per day can be given. Side effects is hemolysis and G6PD deficiency means it will cause hemolysis. Dapsone side effect. And dapsone and pyrimethamine can be used, and dapsone dose is reduced here. Dapsone per what is this?
Leucovorin.
Leucovorin can be used along with pyrimethamine. Or next is pentamidine once in a month. It is given in aerosol, and the problem it is bronchospasm in them. It can cause bronchospasm. And this also can be used. Atwa cone. These charts are from Harrison. You can get that. Now we'll come to this truck driver. Uh, Truck driver presented with a history of fever since 4 weeks, and dry cough. He also gives a history of weight loss, about 10 kgs. X-ray shows bilateral reticulonodular infiltrates, the most likely diagnosis. Truck driver, commercial, sex worker, and male, homo, sexual. These are high risk patients for STD.
HIV.
STD, HIV, whatever. Okay. And drug abusers. Hmm? Drug abusers. These are considered as long distance truck drivers, especially. Long distance truck drivers. And these are what are those? Long distance truck drivers. Then male homosexuals, drug abusers, and commercial sex workers. These are all high risk patients for developing HIV. Okay. Now, so he's a truck driver. Of course, there's no mention of long distance here. Anyway, we'll take it. So this patient has come with a dry cough. So what do you get in tuberculosis? It is a cough sputum.
Yes, sir.
Okay. Bit
Productive cough.
unlikely. Dry cough. Okay. So pneumocystic carni. We'll come to that later. Pneumococcal pneumonia. It will not be like smoldering going on for long days. It is a typical pneumonia. Pneumocystic carni. Sorry, pneumococcal pneumonia produces typical pneumonia. It is unlikely. Interstitial lung disease will not present with weight loss and all these things. So the question here is, it more likely to fit here. Pneumocystic carni along with AIDS. Acquired immunodeficiency syndrome. It is a case more likely to fit there.
Yes, sir.
True statement about pneumocystic jirovecii is often associated with CMA, cytomegalovirus. Always associated with the nematocele. Usually
Occur
diagnosed
with
by sputum examination.
infection occur
Infections
only.
occur only in immunocompromised host. Which of them is correct?
Sir, D.
Infections occur. Infections occur. The question choice is it is infection, not a disease.
It's not, sir. It's not.
Infections occur in infants also. Just now I told you that. Huh?
Sir, C option is the correct one.
So infection is different and development of a disease is different.
Yes,
So
sir.
almost all of us are infected. You can put it that way. And we don't develop disease because we are not immunocompromised. And usually PCP pneumonia is a new infection. These things you should keep in mind. So infections occur in only in immunocompromised is wrong. But PCP pneumonia, okay, this is fine. This is fine. Now, often it's not often, usual, uncommon it is, but it can happen because CMU also occurs immunocompromised. So in PCP, especially renal transplant patients, they can develop this combination infections, but it's not common, not often. It's not often. And always, yes, put it yes. It's not always. It's not always. This patient may not have nematocele. That's cysts I was talking about. It doesn't have that. And usually diagnosed by sputum examination. If I had put it as routine here, I would have said no. Yes, put it bluntly, sputum examination, you can consider it could be induced. Usually diagnosed by induced, correct would be induced sputum examination. What?
Yes, sir.
Induced by hypertonic saline. If that is negative, go for BAL. Okay.
Yes,
Yes,
sir.
sir.
Indications for prophylaxis of pneumocystis carni pneumonia include choose best two options. Two options you have to choose here. So this one is there. CD4 count less than tuberculosis is
Oral
not the
candidiasis.
indication. Viral load not there in the choice, and oral candidiasis.
B.
Oral
A and D,
candidate.
both.
A and D.
A and D. Okay. All of the following are treatment of pneumocystic carni except treatment. Can you give them pentamidine?
Fluoroquinol.
Pentamidine?
Chloroquine.
Can you
Fluoroquinol.
pentamidine? Yes. Dapsone? Yes.
Yes.
Cotlamazole? Yes. But fluoroquinol? No. So the answer is this. Drug of choice for Mycoplasma pneumonia.
Tetracycline.
Erythromycin. Sir, actually, though, it's azithromycin.
Yeah, but
It's
choice is
drug.
not that.
So erythromycin maybe, sir.
Yeah, we can take up erythromycin here. Why not penicillin?
Sir,
Penicillin
beta-lactam,
acts
sir.
on what?
Beta-lactam.
What is the action of beta-lactam? Where it acts? It acts on cell
Cell
Wall.
wall,
wall.
sir.
Ah.
Cell wall synthesis
See,
inhibitor.
beta-lactam, all beta-lactam, which are beta-lactams? Penicillins and cephalosporins. These
Yes,
act
sir.
on what?
Cell
Cell
wall.
wall synthesis.
Cell wall. This Mycoplasma pneumonia, although it is a bacteria, it
Don't have, sir.
Cell wall.
does not have cell wall. Okay. So beta lactam and gram stain are useless here. You're getting me?
Yes,
Yes,
sir.
sir.
Because they are dependent on the cell wall. This organism doesn't have cell wall, so they're useless. So this will be the better answer, erythromycin. I can't deny tetracycline, but erythromycin is a better answer anyway. So mycoplasma, So we'll learn something about the mycoplasma. This is we should remember, this is a typical pneumonia. This causes a typical pneumonia, but it is extracellular. Remember this.
Yes, sir.
Mycoplasma is a typical, but it is extracellular. Remember that exception. It is usually all atypical pneumonias are caused by intracellular organisms. Now, whereas all this is a extracellular bacteria. Lack of cell wall, so gram-stain beta-lactam are useless. Infects both upper respiratory, lower respiratory tract, CNS, joint, autoimmune hemolytic anemia, glomerulonephritis. These are the multi-system it involves. So apart from respiratory tract, next common is CNS. And if it is involving more than respiratory tracts now along with this, it is not a good sign, it is a ominous sign. Patient could be very serious. A patient with a mycoplasma pneumonia, if it develops CNS infection and all that, the patient is more likely to develop more complications. So you should be more concerned about such patient. And most of them are community acquired. Up 40% of the community are acquired, and rest are hospital acquired or ventilator associated, whatever they come here. So 40% are community acquired pneumonias. Clinical presentation is a typical pneumonia, similar to chlamydia. Presentation. This increases the infection. See, this Mycoplasma pneumonia comes and it damages your respiratory tract, epithelium, this, that. It destroys the immunity and it makes these organisms to take over next, viruses and all that. So patient with mycoplasma pneumonia can get complicated with viral pneumonia, streptococcus parasite, neurogenic meningitis, a CNS infection like that. So mycoplasma pneumonia is a sort of predisposition for other complications. So there will multiple infections happen in a given patient. It can happen. Got my point?
Yes.
So less than 5 years, it causes coryza only. 5 years old. More than 5 years, it causes bronchopneumonia. Children. Extrapulmonary manifestations are bad. Hmm? Hmm? In mycoplasma pneumonia, following are seen except diffuse infiltration of lungs. True. Because it produces interstitial type. Cannot be cultured routinely. True. Cefotaxime is a drug of choice. False. Because it's a
False, sir.
beta-lactam. Beta-lactam. Serology is useful. So this is a answer. Because as there is no cell wall, mycoplasma pneumonia, cefotaxime is useless. Treatment of chlamydia pneumonia is what? Ceftriaxone, penicillin, sulfonamide, erythromycin.
B.
Erythromycin.
Erythromycin, sir. Like mycoplasma.
Yeah, erythromycin.
Micromicron.
It is an obligate intracellular anaerobe. Although the clinical presentation is similar to mycoplasma, but it is an obligate intracellular anaerobe. So this apart from chlamydia causing pneumonia, it can cause long-term chronic infections and chronic diseases in the humans, especially this atherosclerosis. It can cause. It can cause lung cancer. It can cause diabetes, Behçet's disease, arthritis, biliary cirrhosis, asthma, and Alzheimer's. These are all implications. It has got some association with these many diseases, chlamydia. Okay.
Yes.
These are it can cause all multi-system involvement also on long-term basis. Acutely, it causes pneumonia. Okay, you should know that.
Yes.
So if they're asking Alzheimer's is caused by some virus and all that, some of this you can pick up this answer here. Chlamydia you can take all of that. An elderly man admitted to for pneumonia presented with diarrhea and gripping abdominal pain for 5 days. Discharged from hospital. Drug which is likely to benefit is. So 10 days less than hospital discharge.
Legionella.
Legionella, yeah, Legionella. Which is a drug? Yeah.
Levofloxacin.
So what's the first drug?
Levoflox.
Legionella. The drug.
First is drug of choice is, sir, azithromycin.
Azithromycin. And if not, you can use levofloxacin, fluoroquinolones, because moxifloxacin, getifloxacin, what is gemifloxacin, these things, levofloxacin, these things, and getifloxacin. So this is the case of Legionella. See, there's diarrhea. Where is this? Yeah, diarrhea is this here. 10, 5 days within discharge. Okay. It is Legionella source. Okay. Commonest sign of aspiration pneumonia is cyanosis.
Cyanosis, sir.
Okay. Cyanosis you get in a yard, yes, if there is a complication. limitation. All patients don't get hypoxia, man. Ankit Arora, you forget murder case. Everybody will not become like that. You'll develop that. That movie is different. Okay. Cyanosis is not everyday seen. Aspiration pneumonia, we keep on seeing so many times. So aspirations, they're pretty common in the world, people. Huh? Oh, it is. Commonest sign is aspiration pneumonia is tachycardia. Huh? Okay.
Yes, sir.
This is the end for today. If you want to ask any doubts, you can ask. Prabhakar, and some new person had come. I want to talk to him. I just forgot. He left, huh?
No, sir. He's in.
Any doubts?
Sir, if